Okay, good evening. For this lecture, I really thought you'd rather see me in the classroom where you're used to seeing me. So back to nursing school we go, and let me share my screen and we will move on to the next cancer presentation. Okay, this part is part 2 of the cancer series for the class this time. We're going to be talking about the care, the types of treatments, the medications, complications of cancer. It's a long presentation, so bear with me, and then we'll start moving into the separate exemplars after this. So cancer has 3 major goals. We either want to cure it completely. If we can't cure it, we want to control it. So allow it to not grow and let the person live as long as possible at the good quality of life. And if cure and control doesn't work and they do enter later stages, then we want to have palliation. We want to do the things that make them feel better and allow them to have a life um, that they can respectfully and with dignity live out till its end. So here is the graphic from your book that talks about the goals of cancer. There's multiple treatment paradigms. We have chemotherapy, surgery, we have radiation therapy, biologic and targeted therapies. And then of course there's diagnostic phase is the first step. First we have to get you diagnosed, then we start treating you. Once the treatment plan is decided, we know that we're either going for cure, which is our first goal, we might be going for control, or we might be going for palliation. Now, for cure, surgery, chemotherapy, and other forms of therapy are all primary. Radiation, biologic therapies, all primary. But we go for that initial cure, and so surgery would be our first step, and or chemo. And then following that, then if we can't do that, remember control. And then surgery, chemotherapy, radiation therapy, biologic therapy are all included in control as well. Some of them are also included in palliation, chemo, surgery, radiation. We'll be talking about each of these stages we go, and each treatment is used differently in those stages. But of course, cure is our first and primary plan. So how do we decide how we're going to treat cancer? Well, we have to get a good, thorough diagnostic process going. We have to know what type of cell it is, how fast it grows, where the tumor is located, how extensive it is, as it metastasizes in the lymph nodes. We need to know the patient's overall physiologic and psychological status, because some treatment modalities are a little more complex and some are a little more fatiguing. We also want to know what that patient's desire is. Remember, patient-centered care revolves around what that patient's desire is first. And we help them participate in the plan, and we follow their preferences. So curative therapy can be just surgery, complete removal of the tumor, and that did it. More often than not, though, it involves surgery plus a follow-up therapy of some sort to make sure we got all the random small cells that we might have missed in surgery that were already in the circulatory lymphatic system or had already started to creep into surrounding tissues. The control treatment is the initial course of chemotherapy and the maintenance therapy or radiation. And then palliation will be controlling symptoms, maintaining the best quality of life as we can for a patient in a cancer that we're unable to cure. Surgery is the oldest and primary form of treatment for cancer. We can do a preventative surgery right from the start, or we can go ahead and use it as initial treatment, or we can use it for palliation of symptoms. So prevention is to remove an organ that you believe you could likely get cancer in. So a woman with a family history of direct relatives, mother, sister, grandmother, whatever, direct relative with breast cancer might choose to have a prophylactic mastectomy. I have a friend who had a family history of gallbladder cancer, so she had her gallbladder removed before she had any symptoms. So those kinds of things are prophylactic removal of non-essential organs. We can't remove both kidneys or a brain or a heart, obviously. So it's usually done for non-essential organs. And it's usual in a place where, where we think that cancer is likely to start and regional spread can happen easily. That's why breast is such a common place for this, because the lymphatics are so rich in the tissues around the breast tissue. And if we miss an early diagnosis, the spread of it is pretty easy through the lymphatics. So again, surgery is for cure and control. So if we can't cure it by complete removal, and we're going to take as much tissue as we can with the goal of getting clean margins. We want at least a 2 millimeter clean margin around any tumor size. The smaller the tumor, the better the surgical outcome is, obviously, less tissue destruction. And we also want to look for an absence of lymph node involvement, because if you don't have lymph node involvement, your surgery is more likely to be curative. Later in cancer, again, if you can't get cure, a debulking procedure can be used. That would be, we couldn't get all the cancers out. It was too invasive. It was spread out in too many organs. So we can take large pieces of the tumor out to remove symptoms. And then we can follow that up with chemotherapy and radiation to shrink the tumor. Shrinking the tumor through surgery before we do the chemotherapy and radiation can be a very effective way of getting the treatment to a manageable size before we start treating it with drugs and radiation. Also, the supportive and palliative care can include surgery. If somebody's in end stages or needs palliation, we might use surgery to insert a feeding tube or put a colostomy in, to place a venous access device, a portacath, to remove metastatic lesions on a site, again, to provide debulking. So those kinds of things can all be surgical approaches that help support a patient who has cancer have better treatment outcomes, and a better quality of life. Surgery can also be used in a rehabilitative mode. It could be reconstructive, like after a mastectomy, to reconstruct breast tissue, or after an amputation to make it a more palatable surgical site. A closure of a colostomy that might have been temporary could be a rehabilitative surgery. Creation of a bladder reservoir, a urostomy for bladder cancer might be something that has to be done. Those are all surgery used for rehabilitation to get body function back, if not through normal routes, but through surgical routes. And then chemotherapy is the second major foundation of cancer treatment. If you think of cancer treatment as on some kind of tripod or quad pod, there's the cancer tumor, and then we treat it through surgery, we treat it through chemotherapy, we treat it through radiation, and we treat it through targeted biologic therapies. Those are our four major treatment ways. Okay, so chemotherapy is the second major leg of treatment, and that's the use of chemotherapy, chemicals, drugs, think pharmacotherapy, as a systemic therapy for cancer. It's systematically delivered generally through IV sites, but there's other routes of provision, and we're going to go into those in a minute. So the goal of chemotherapy is to kill as many of the malignant cancer cells as possible. We're going for cell kill. Chemotherapy is the mainstay of treatment for most solid tumors after we've done surgical removal. It's also the primary treatment for leukemias, lymphomas, and the other hematologic cancers. It's hard to do surgery on a hematologic cancer or radiation, because radiation causes hematologic cancers, although we do it sometimes. So the goals of chemotherapy, again, cure, control, or palliation. And chemotherapy, if you think it's cell kill, it's killing cancer cells. So it's making that tumor smaller, it's making it have less bulk. And of course, we know that we have great results with chemotherapy alone on several types of cancer. Burkitt's lymphoma, a Wilms tumor, which is a kidney tumor on a child, generally on a preschooler, neuroblastoma, ALL, acute lymphocytic leukemia. It's probably the most common childhood cancer we have, but it can affect adults too. Hodgkin's lymphoma, cancer of young adults through the lymphatic system, and testicular cancer all have curative rates generally with chemotherapy. We use chemotherapy as control in breast cancer, non-Hodgkin's lymphoma, small oat cell cancers, and ovarian cancers. And palliation, if we can't get cure or control on our cancers, like especially pancreatic cancer, some of the other lung cancers, including small oat cells sometimes. We'll use it to relieve pain, relieve obstruction, improve the patient's sense of well-being, and just how they feel by shrinking the tumor, making the tumor less active in their body. So how do we decide what chemotherapy we're going to use and what types, what combinations, and how that patient's tumor is going to respond to chemotherapy? First, we have to know, remember we talked about good diagnostic testing initially. So the staging, grading, and the histology reports on those cancer cells tell us what kind of cell is it? Is it mucous membrane? Is it connective tissue? Is it hormone receptor positive? Are there surface antigens? What can we do to know all we can about that cell and the type of antigens it has? We also know if it's a small tumor, we have a better response. If it's a new and young tumor, so not a well-established large tumor, that we're going to have better response. So a young tumor, something we catch early. The location of the tumor can be indicative of treatment success with chemotherapy because it has to have a good blood supply most of the time to use chemotherapy. We can't get chemo directly into the brain unless we use a shunt directly into the brain tissue, which we'll be talking about in a minute. But also, we can't get a lot of agents just won't cross the blood-brain barrier. And then also, we need to know if those tumor cells are resistant to any type of therapy. That can come from the outset of a tumor where just certain types of chemo won't work on a tumor, but it also can develop if you've been using a kind of chemotherapy and the tumor starts regrowing. We might discover that tumor has become resistant to one of the chemotherapeutic agents we were using. So what does chemotherapy do? Chemotherapy acts on one of the stages of the cell cycle. So it acts on mostly the dividing cells, most often the most rapidly dividing cells. Cells that are in the G0 resting phase have less effectiveness or don't respond as well to chemotherapy. If they're in a non-cycling phase, they can be resistant to a lot of our chemos. So, and as the larger the tumor is, remember young and small tumors are more effective. The larger the tumor gets, the more cells enter a longer-term resting stage and they're not as active, but they're still out there. So we have chemotherapy that works on various G stages, the M stage, the S stage of the cell cycle. And so we pick our chemotherapy in clusters and groups to act at different stages of the cell cycle. Another thing we need to know is the molecular structure of the chemotherapeutic agent and how it acts. Is it cell cycle non-specific or cell cycle specific? And we'll often give you a combination of drugs that work across all cell cycles and some that work only in the M stage, only in the S stage. So we get a cluster, a medication that acts at different stages and in different ways. So if we give one combination drug with one chemotherapeutic administration with 3 or 4 drugs in it, it can hit lots of different times of the cell cycle and overall tumor growth, so it can get the maximum amount of cell kill per dose. The cell cycle specific drugs typically fall in the categories on the left-hand side of your screen: the alkylating agents, the nitrosoureas, the drugs with platinum-based, anti-tumor antibiotics, corticosteroids, and hormone therapy are all non-specific. But we have antimetabolites, mitotic inhibitors, and topoisomerase inhibitors that are all cell cycle specific. Those are categories of chemotherapy. When we talk about cardiac pharmacology, we talk about categories of drugs. We talk about antiarrhythmics and antihypertensives and positive ionotropic agents. These are the classifications of drugs for chemo: alkylating, antimetabolites, mitotic inhibitors, topoisomerase inhibitors, hormone therapy. So the book talks about those in various charts. You certainly can look. There's a great chart in your textbook that talks about drug therapy and the cell cycle specificity of it. One of the things the nurse also needs to know about chemotherapy is not just how it's going to work, what cell cycle it's going to work, what drugs are given in combination, but also if we are helping to prepare and administer these medications, these drugs are cytotoxic. That means cell kill. They're not specific to which cells. So if you touch them, splash them, or get them on your clothing and then touch that clothing, you inhale the vapors, they can all have an effect on the nurse's body. So they are an occupational hazard. You have to be careful about splashing, inhalation. You should go through some kind of chemotherapy administration training before you give these drugs. If you are preparing and administering chemotherapeutic agents, you should always wear gloves. The Cancer Society, the CDC, recommends 2 pairs of gloves when you're giving chemotherapy. They also recommend an N95 or similar cartridge filter mask, a face shield or goggles, and a gown when you're preparing or administering chemotherapy. So you have to wear your PPE to protect you in this case. Quite often, PPE, we might be protecting the patient from us in chemotherapy because the patient's immune suppressed. But when we're administering chemotherapy, we're protecting us from the splash and the hazardous chemicals. We're not protecting us from the patient's sputum or blood, but we are protecting us from the agent that we're giving. Chemotherapy can be given through an oral tablet, capsules, tablets, liquids, orally, intramuscularly, least common, intravenously, most common. Intracavitary, that means we can directly administer them to a body cavity, like a bladder or a uterus. Intrathecally, that means we're administering it straight to the spinal CSF, the cerebral spinal fluid, into the intrathecal space, like where we gave spinal anesthesia or other spinal medications. So the intrathecal space, there's one at the top of the vertebrae, at the top of the spinal cord, at the base of the skull. There's also intrathecal spaces in and around the vertebrae. So we can give intrathecal chemotherapy. We also can give intra-arterial. If we know we have a tumor at the end of an extremity and the arterial supply is going straight to it, we can administer chemotherapy through the artery that's going to carry it directly to that tumor. We wouldn't give it through a central artery, but only in an artery arterial headed directly to that tumor site, so it gets to the cells of that tumor first. Most of the time, chemotherapeutic drugs are given by routes that enhance perfusion, like IV, intra-arterial. Chemotherapy can be given continuously or through bolus dosing. We have bead seeds of chemotherapy that can be placed subcutaneously or directly in tissues that slowly release chemotherapeutic agents. We can give subcutaneous chemotherapy, and there's topical chemotherapy for skin. So most chemotherapy can be an irritant or a vesicant. An irritant means that it's irritating to the vein, but it doesn't hurt the surrounding tissues. A vesicant is a chemotherapeutic agent that can leak out of the vessel, damage the intima of the vein, but also leaks out. And when it extravasates, or when you have an infiltrated IV, it will kill the tissues and it causes tissue death. And so nurses have to monitor IV sites very, very carefully in chemotherapeutic patients. You need to make sure you know which chemotherapeutic agents, when they do have any kind of infiltration out to the tissue, that you know if you're supposed to use hot or cold therapy on it, because for some you put an ice pack on, for some you put a warm pack on. We're going to talk about that more in a little bit. It's also discussed in your book. We also want to be sure that we know what to do if we notice that IV site is starting to infiltrate or there's irritation. We're going to stop that chemotherapy infusion, and we're going to make sure we notify the healthcare provider, because there might be an antidote that we can give. Quite often chemotherapy has antidotes, and so we would inject that antidote into the site to start to reverse the cell damage, the tissue damage. So ongoing with methods of administration, because of the vesicant problems with so many of the chemotherapies, remember, they kill cells, they'll kill tissues around their IV site just as easily. So we will often use a central venous access device, not just a central line like we see in the hospital, a triple lumen central line. But we also can place ports into the central circulation, or a catheter that goes into the vena cava, and then it tunnels subcutaneously to a site down the arm or down the abdomen, so we have access to that. There's different names for these, a Portacath or a Gershon catheter, Hickman catheters, Broviac catheters. They are all central lines that are either accessed through a subcutaneous port or through a tunneled catheter. There's some pictures here that just show you what I'm talking about. Then if you're going to access a port, like a portacath under the surface, you've got a little port inserted up here, usually on the upper chest, and then it's going directly to the superior or inferior vena cava. And then we will use a non-coring needle. So a needle, when I stick it through the rubber port on the implanted port, it won't make holes in that port. So the port will close right back up afterwards. So a needle that won't take a core out. It's a special needle. We also have a needle that's a 90-degree angle. So the needle goes down and then it turns sideways at 90 degrees. So you can, while you're giving the chemotherapy, you can put it in the port and it lays flat against the skin and hooks to the IV tubing for administration. And you give your dose and then turn it off and then come back the next day, give another dose. And then 2 months later, a month later, they can come back for another round of chemo. So that port can stay in long-term for several months, and we can just keep administering chemotherapy through it. It saves the patient lots of multiple sticks. Same thing with the tunneled catheters. The patient or the nurses would just hook the IV medication up to the end of that tunneled catheter. Remember, it has to be sterile access because like a central line, these are going directly to central circulation. So you want to be very cautious about your infection control. Patients that are going to be managing this at home, like with a Hickman or a Broviac, where they may be administering their own chemo to the site, need to be taught sterile technique. Regional administration, like to or intra-arterial or intrathecal or I don't know, any of the types of tumors that are delivered directly to a site and not given through central circulation can be done. We talked about the routes earlier. They're generally given in high concentration because it's going straight to the tumor. So we can give higher concentration of the drugs than we would if it was going to be initially circulated through the whole body before it got to that tumor. So intra-arterial, intraperitoneal, intrathecal, intravesicular, again, peritoneal, the peritoneal space all the way around the abdominal organs, into the ventricular or intrathecal spaces, or into the bladder, where we put it in through a catheter. We allow it to dwell. We call that dwelling. We just let it sit in the bladder for a couple hours, and then we drain it out through the catheter. So what does chemotherapy do to normal tissue? It is a drug that causes cell kill. Cell kill. So cellular destruction tends to make the patient always fatigued, anorexic. It kills rapidly dividing cells first. So the mucous membrane cells. So the patient might have taste ulcerations because mucous membranes in the nose and the mouth contribute to our taste. Anorexia, where they just don't have an appetite. There's acute side effects, delayed side effects, and chronic side effects from chemotherapy. We give drugs in combination, and we calculate those drug doses based on the patient's body surface area. And we want to get drugs that act differently. And we want to try and space out the serious side effects. So if you have a drug that gives you strong emetogenic properties, you don't want to give another strong emetogenic drug with that drug, or the nausea and chemotherapy-induced nausea might be overwhelming. You want to give them one that might cause anorexia or anemia, and one that causes the emesis. All the side effects are not nice, but we don't want to pile up the same side effect in really high doses. So we're going to figure out the combination that's right. There's been lots of studies done on which combination chemotherapy is best for different kinds of cancers. And as you read through the reading on specific cancers, you may see that therapy listed somewhere. So we know that the patients can have tolerable side effects and toxic side effects. Toxic side effects may not be reversible. Nephrotoxicity, ototoxicity, gonadotoxicity. So the patient might come out of chemo with some hearing loss or neurologic damage or renal function loss or sterility. So this is, nursing diagnosis, such a big thing in our world, which we don't really teach NANDAs all the time anymore, but you need to know if a patient's on chemo, what kind of problems are they going to have? What are they related to? So we know how to plan our interventions to treat them. So they might have mucous membranes that are altered. Most chemotherapy causes stomatitis. Your oral mucous membranes are rapidly growing, and so they get ulcerations and damage to the mucous membranes in their mouth. Um, they also can cause xerostomia, dry mouth. So we want to be cautious to keep their lips and their mouth lubricated. We want to make sure that they don't have decreased nutritional intake because of soreness when they eat. We want to give them bland, soft foods that are highly nutritive, rich in protein. We want to try and encourage oral intake because it's going to, you know, when you have this ulcers, sores in your mouth, it hurts all the time. So you just want those patients to be very careful and be aware of that and treat them. And when they get them, the doctors can prescribe special things you swish and swallow that can numb it and ease the pain related to it while the tissues heal. The patient might have activity intolerance because they're going to get profound anemia from the chemotherapy. And if they're anorexic and not eating enough, they'll have an imbalance of calorie count. Tumors use a lot of calories to grow. They're rapidly dividing cells. That means they produce a lot of ATP. So the patient might have a calorie imbalance where they are eating a certain amount of calories, but their tumor is using so many of them, they have a negative calorie balance, and that might contribute to fatigue. Because of their anemia, they might be fatigued. So you just want, their pain might cause it, their anxiety might cause it. You just really want to pay attention to it, let them rest, and provide them needed interventions, clustering your care, uninterrupted rest, decreased anxiety, maybe timing certain care with the dosing of their medication if the medication itself has fatigue as a side effect. If the patient has nausea, then we're going to do all our nausea-related interventions. We have some slides on that in a little bit. We'll talk about it. The body image disturbance could come from the hair loss, alopecia, because hair follicles are rapidly dividing cells. So what do we do about that? We let the patient wear scarves. We let the patient embrace their baldness, maybe put on makeup techniques, or a lot of patients will go ahead and shave their head before the chemotherapy so they don't have the falling out patchy hair. Some patients will cut their hair, make their own natural wig out of their own hair. There's also places that people can donate hair to make wigs for patients that have alopecia. So we want to potentially treat them with wigs or scarves, makeup techniques, all kinds of things can be used to help increase self-esteem. And remember, if they're going to get hair loss, it's all the hair. Their eyebrows are going to be gone. Their eyelashes are going to be gone. So there might be a whole variety of things that they're happening, not just baldness on their head. You know, so you'll see patients paint on their eyebrows and put on artificial eyelashes, whatever it takes to get through this period of time. Most of the time, the alopecia is transient, and after the chemotherapy side effects wear off, they regrow their hair. It may come back in a different texture, a different color, maybe curly instead of straight, or vice versa, but it often grows back most of the time. Patients will have knowledge deficit about their drugs and how they manage the side effects. The family is going to be scared. There might be safety precautions, especially dealing with these drugs. And sometimes the medication regimes can be complicated. Give this drug at 8, 2 hours later give this drug before it starts. And that can be overwhelming for families and individuals that are managing their own medications. So we want lots of things like calendars and pill boxes and reminders in their phone to help them stay on track. Let's see, all the chemotherapy is going to reduce the body's own natural protective devices. So they're going to become immune suppressed. Their own white count is going to drop, so they won't have adequate T cells, B cells, killer T cells, all that stuff is going to be suppressed. They'll have thrombocytopenia, making it harder for them to clot, and they might bleed and bruise. They might have bone marrow suppression from the chemotherapy, and the bone marrow, remember, is where we make red cells, white cells, and platelets. And so if bone marrow suppression occurs, that's going to cause pancytopenia, general overall decreased immune functioning. So lots of things to think about with a patient who's on chemotherapy and all the side effects from it. So these are very common side effects from chemo that you just need to be aware of. You're going to have nausea and vomiting. Quite often, chemo-induced nausea is the single biggest debilitating thing our patients can complain of. It can be persistent. It can be overwhelming and difficult to manage. We're going to talk about managing it a little bit. Bone marrow suppression, again, white cell, red cell, and platelet reduction. Anorexia, where food doesn't taste good and they're just not hungry, but at a time they really need increased calories and increased protein. They may get GI disturbances, diarrhea, or constipation from these medications, hair loss, the alopecia, and that is a person who isn't saying don't get fat, although we don't want that. We also don't want them to get pregnant because chemotherapy kills rapidly dividing cells. Well, what is a fetus? A fetus is a small cluster of rapidly dividing cells creating a little mini human being in your belly. So chemotherapy will hurt a baby if the mom is pregnant. So the type of chemo can be adjusted. We can use maybe some antibiotics, maybe some other therapies, but in general, we're going to recommend the woman not get pregnant while they're going through chemo, and that if they have a cancer diagnosis while they're pregnant, that we delay the chemotherapy for a few months until the baby's born. This chemo man has been wandering around the nursing world since I was in school. It just uses letters of the alphabet to help you remember where the side effects of certain chemotherapies are. Like the N at the top of the brain, see up here, nitrosurias, that category of drug causes alopecia. The V's in the extremities, see the fingers and toes are V's, those are the vinca alkaloids, they cause peripheral neuropathy, right? The N is also neurotoxic, so it's going to cause neurologic damage. The D, doxorubicin, that's adriamycin, doxorubicin is the most cardiotoxic chemotherapy there is. So this is just meant to help you remember some things about drugs. C, cisplatin, it goes where the kidneys are, makes little kidneys, so it's nephrotoxic. B is toxic to the lungs. It causes fibrosis in the lungs, pulmonary fibrosis. So just kind of chemo man to help you remember side effects. Not important, you remember them. No question will say, where is the V on chemo man? Okay, so again, we want to teach our patient to monitor for as much as they can. So we're asking them to prevent infection. So they need good hand washing. Stay away from children with acute communicable diseases, runny noses, who've recently had live virus vaccines. Don't pet your cats and don't let them scratch you, and don't clean out the kitty litter or the bird cages. No fresh flowers, neutropenic precautions. Don't go out into crowded places. This is the time to avoid Texas Stadium, American Airlines Terminal, and going to Walmart. No gardening because of the dirt and the thorns and the briars that can cause surface fungi to come in. If you do garden, always wear gloves. Be very careful with protective garments. And then they do need to go outside, but they also need to come inside, get a lot of rest, and provide lots of time for rest so they have healing and to support their immune system. We want this person to prevent injury because of the thrombocytopenia. They're going to be bleeding and easily because they don't have enough platelets. So avoid contact sports or heavy sports or activities that cause a lot of body blows. If they're going to shave, they need to use an electric razor, not a straight edge razor. Even a safety razor can be more dangerous than an electric razor. Soft toothbrushes rather than firm toothbrushes to avoid gum bleeding. Change their position slowly. Don't grab a hold of them. They're going to have some orthostasis, maybe from the fluid changes with the cancer, so we don't want them to pass out. So change position slowly, because if they fall, they're likely to bruise and really hurt themselves. And if they're bleeding, we want to have some kind of transportation arrangement so they know who they can call quickly. We want them to maintain their nutrition. So high antioxidant foods are good for cancer prevention and maintenance. Antioxidants are food like cruciferous vegetables, citrus vegetables, foods that are high in vitamin C, vitamin E. Those types of foods are antioxidant. They get rid of that free radical oxygen that is damaging to tissues. So it's really good for that. You also don't want that person to get too little or too many calories. You don't want them to lose excessive weight, but we don't want obesity, because remember, obesity is a promoter of cancer. If they have it, it's just going to continue to encourage its growth. So healthy BMI is our target, and adequate fluid intake, which means 10 8-ounce glasses or more, so between 1.5 and 2 liters of liquid a day. Nausea and vomiting is an overwhelming problem. So eat small, frequent meals. Eat 6 to 8 times a day, small amounts of calories. Split your dry foods and liquid foods. Sip on liquids at a different time than when you're eating your dry food. Provide good oral hygiene so they don't have a bad taste in their mouth. Ginger and peppermint are both over-the-counter treatments for nausea and vomiting. They can help. There's a medication regime that we're going to go through for this shortly, so hang in there for that. So we want these patients to watch for side effects and toxic effects and report them if they notice signs of them. Alopecia is a side effect, not a toxic effect. People don't die from baldness, but they get body image problems. It's disconcerting, and for some people, it's pretty devastating. So again, we want to teach that. Nausea and vomiting, side effects. We want to teach our patients to begin their antiemetic regime, Zofran, our serotonin antagonist, before the first dose of chemotherapy and regularly throughout the chemotherapy, generally for up to 10 to 14 days afterwards, because some of these chemotherapeutic agents have a long half-life and the patient may be nauseated for a week or two. Anorexia is a side effect. It's not always toxic, but if they lose enough of their body weight, it can be. Fatigue, peeling skin and rashes are not uncommon with chemotherapy. Or dry skin is pretty common with chemotherapy. Wet skin and dry skin can both be common with radiation. We're going to move into radiation in a minute. Mouth ulcers, mucositis, that's stomatitis and mucositis in the mouth. Painful, can decrease their food and fluid intake and cause the patient a lot of pain. Fungal infections, hard to cure, easy to get. There's lots of fungus out there in our society. So candidiasis on the skin, so it could be a problem. So you want to keep skin folds dry and clean. So could other fungal infections could come from gardening, where they get a little cellulitis from a fungus. Could turn into a big deal if your patient is immune suppressed and doesn't have adequate white cells to fight an infection. Bone marrow suppression in general, a very toxic side effect of chemotherapy. So radiation, another treatment modality for cancer. Shift positions here. Radiation is another common treatment modality. Remember, chemotherapy was one of the legs of our tripod. Radiation's a leg. It is old treatment. It is one of the oldest non-surgical methods. Over 50% of all cancer patients will have radiation at some course in their treatment. Quite often it goes surgery, radiation, chemotherapy, or surgery, chemotherapy, radiation, but it's more common to see surgery, radiation, chemotherapy. And it kind of depends on what cancer they have and whether it's responsive to ionizing radiation or not. Problem with that is the ionizing radiation also causes cancer. So people who've had this are more at risk for cancer later in their life, maybe 10 or 15, remember that 10-year, that cancer 100-day doubling time? I may get a mutation from the radiation today, and 10, 12 years later, a new tumor is clinically detectable. So that's something you just want to be aware of when somebody has radiation therapy. So the amount of radiation we give depends on the patient's body surface area, the type of cancer they have, the susceptibility of that cancer is to radiation, how much emissions the radiation actual chemical that we're using is, the element that we're using is, and how much of it's distributed. So the radiation produces ionization of atomic particles when it's in the tissue. That generates some free radicals that breaks the DNA bonds and breaks down the cancer DNA, causing the cancer to not reproduce. But remember, it's going to affect all cells. So normal cells can also be affected. Normal cells usually recover, though, because the body doesn't filter them out and all that. Cancer cells are more susceptible to ionizing radiation than normal cells are. Usually cancer is, the doctor's going to choose a low energy beam or a high energy beam. Low energy beams expend the energy quickly. They only go a short distance and they're good for superficial tumors. High energy beams penetrate deeper and they can get high dosing of internal tumors and they can spare the skin. The low energy beams that have a broad exposure over the skin and only penetrate into the skin or mostly to the skin, that's going to have more skin complications. Radiation can really mess up your skin. Both types can. So radiation, the dose is going to depend on the size, the type, and the setting you're in. The type of device the doctors use to deliver the radiation can have a lot to do with it. The total radiation dose is divided into fractions, and usually they get 5 days of radiation, a day or two off, then 5 more days of radiation for up to 8 weeks. Sometimes it's 30 days, sometimes 60 days. 60 days would be 8 weeks. The radiation is measured in grays or rads, but usually we talk about grays. The radiation absorbed is a rad, and the radiation expressed is the gray, technically, so whatever. You're going to hear those terms when they're talking about radiation dosing, so I just want you to kind of know that's the measurement. The number and strength of the radiation is based on the mitotic rate of the cell and where we think it's happening. So a rapidly growing cell is going to be more susceptible to radiation because the DNA is more active, so we can destroy that DNA and stop it from reproducing, all the better. Radiation can be given through external beams, or it can be given through internal dosing. It can be primary or definitive therapy for some cancers. Radiation is the #1 treatment, first and foremost. It can be used as an adjuvant to another treatment like surgery and then radiation. It can be used prophylactically for some problems. It can be used for palliation to shrink up tumors and make sure that that tumor is not pressing on the spinal cord or on a vena cava, causing other symptoms. So the radiation oncologist will work with the primary diagnosing oncologist, and then they will define the treatment field. They often will use permanent markers and tattooing to mark the treatment field. Patients should be told not to scrub or try and get those marks off because they'll be using those marks for several weeks as they get their radiation therapy. What we do, then they go through a period of simulation radiation. It's a CT scan, a large bore CT scan that can mimic the treatment to the tissues. And we actually will mark the fields and target the depth and know how much of a strength of a beam we need to use. And that's called a simulation treatment, and it's done before the actual treatment. Okay, and then we start the actual radiation treatments. So external radiation is called teletherapy. It's given through a cyclotron or a linear accelerator, and to some extent through a gamma knife technology. Gamma knife surgery is actually a surgery where you use a targeted cobalt to excise the tumor. But the cyclotron and the linear accelerators are the most common external beam radiation there is. What we do is we put the patient in, target the film, line up the accelerator over that target with the right amount of radiation, zap it for a few seconds to a minute or two, and then remove the patient from that room. The patient will no longer get exposed to radiation. So just while that beam is expressed, the patient has radiation passing through the body. They bring no radiation out of the room with them. Their body is not radioactive. Their tissues aren't radioactive. Their excretions are not radioactive. The radiation passed through their field during this external beam therapy. Okay, I think I mentioned all of these. The patient's not radioactive. This is just the same thing I talked about. The deal is you can't be in the room while they're getting the external beam radiation because the nurses might be exposed to that radiation, and we don't want to be exposed to that. We will stand behind a lead wall, wear lead cover up, whatever. So it's like in X-ray, where you'd stand behind the wall with appropriate protection from X-rays. In this case, our protection has to be lead and has to be protection from radiation. And then internal radiation is brachytherapy. There is sealed source and unsealed source. Brachytherapy, let's see, systemic, unsealed source, and sealed source, yeah. Okay, so internal radiation, sealed source. Sealed source, internal radiation, brachytherapy. We'll put a catheter or some kind of device through the patient's skin, into the place where the actual tumor is, and we will implant or insert radioactive materials. Sometimes those radioactive materials can be a pellet that's left in for a period of days or weeks or months sometimes, or sometimes the radioactive material goes through the catheter to directly to the tumor site. It's left there for a few minutes and then it's removed. And then we check the patient to make sure there's no retained pellets before we release them for the day. So there's both types where it can be implanted and left for a while, or it can be just in a timely manner given, left in place for a few minutes, they come out, but we leave the catheter in place so the next day they can come back and have another radiation therapy. So if the patient has brachytherapy, as long as that radioactive pellet, seed, whatever is in their body, they are expressing radiation. So anybody in their vicinity is likely to be exposed to radiation. So the nurses and the other healthcare providers that are working around that patient need to organize their care. So we only go in for limited periods of time, and we wear appropriate shielding devices when we are taking care of that patient. So we'll have lead aprons on and just the various, the shielding. And you should always, if you're caring for a patient with radiation, implanted radiation therapy, sealed or unsealed source, you're going to wear a film badge, a radiation film badge on your lab coat or your uniform. Every time you go in that patient's room, you should have that radiation badge on to measure the exposure to radiation you're having. And that's done to keep you safe. So each month they'll check it. If you work on a floor where we're taking care of radiation patients, if your levels are getting high, they won't just replace your badge, they'll actually alter your care assignments for a while. If you're taking care of patients with implanted radiation, you should space out those patients. You don't take care of multiple patients in a day. If there's 5 patients on your floor with implanted radiation, then that should go to several different nurses, not just one nurse. So one nurse shouldn't have several patients. All right, and then if the patient's taking unsealed source, so sealed source, we put the little pellet in, that pellet is what's radioactive. It's a solid bead, seed, thread that's implanted in the tissue close to the tumor, or it's a seed that was put through a catheter to the tissue for a period of time, removed, and they come back the next day for it. While the seed is in whatever type you're getting, the patient is radioactive. Unsealed source, this is systemic radiation. The patient is given radiation by intravenous, or they drink it, or whatever. There's different kinds, quite often intravenous route with a radioactive isotope. The most common one is iodine-131 given for thyroid cancer. While the patient is having this kind of treatment, they either drink or have an injection of this radioactive material. All their body fluids are radioactive. They aren't emitting radiation from their bodies so much as like, I'm not sending out radiation waves, but I drank it. My metabolism is processing through my body fluids, so my blood will have radioactive materials in it, my urine will, my bowel will. So all of my excretions, saliva, will have radioactive material in it. So you want to use barriers on all the surfaces. You don't want the patient's saliva to splatter and sit on countertops. You want trash and linens to be disposable, everything, disposable gowns, disposable plates, disposable trays. All those things can be disposed of without touching them. If the patient has to go to the bathroom, I'm going to flush the commode at least twice to make sure the radiation and the fluids and the radioactive materials flush thoroughly into the sewer system. Going to limit visitors to these patients, sealed and unsealed source. Visitors only can come in for just a few minutes, and they just stay at least 6 feet away. We also want these patients with unsealed source, ask them to report chills, perspiration, fever, nausea. Those are side effects and complications of radiation. Make sure all patients on sealed and unsealed source are getting a balanced diet with small, frequent meals. Nausea and vomiting is pretty common with unsealed source radiation. Most patients with unsealed source will have a Foley catheter, and they'll be given a low fiber diet because we want to minimize the amount of stools they're having and contain their urine so it isn't spilling or splashing or splattering or leaking or dribbling. Usually in healthcare, we're encouraging high fiber diets. This is kind of the opposite. We actually, it's going to be in for 2 or 3 days. We want to minimize the patient's stooling, and we want to contain all their urine. If the patient throws up, that emesis is radioactive, and nausea and vomiting is pretty common as a side effect. So you'll cover the emesis with some kind of water barrier pad and call your hospital radiation officer. Hospital radiation officer is going to be closely taking care, helping with the care of both sealed and unsealed source radiation patients that are inpatient, because they're going to be exposing staff, and they need to make sure all the appropriate tools are in place. When somebody has sealed source radiation, they often place a little lead container in the room with lead forceps. So if something falls out of the patient, like the patient has a cervical radiation implant or a uterine radiation implant, and they're moving around, they're supposed to be on bed rest, limited movement, minimizing their up and down out of bed. But if they get that and then they sit up or they move positions, they notice something's fallen out, you should pick up that, put on lead gloves, pick up that substance with your lead forceps, put it in the lead box, and call your radiation office. All right. There are some commonalities to chemotherapy and radiation. We're clustering the commonalities together so we can talk about treatment for them together. Bone marrow suppression, fatigue, GI disturbances like diarrhea, integumentary skin reactions, mucosal membrane reactions, pulmonary effects, and reproductive effects. And we'll be talking about these. So bone marrow suppression, myelosuppression. Oh, I went too far. Sorry. Myelosuppression, the most common side effect of all of our chemos. What happens is we give the chemo, bone marrow is rapidly dividing cells. Our complete blood replaces itself every 120 days. Each cell has die-off and replacement. Now, it's obviously not all on the same day. It's cyclical, but they're rapidly dividing cells. So the chemotherapy or the radiation causes suppression of the bone marrow. So you have reduced red cells, anemia, reduced white cells, infection, and reduced platelets, bleeding. So they have pancytopenia is what that's called. So they'll get infection, hemorrhage, and fatigue. So when the patient is fatigued, you want to do your care more so in the morning when they're feeling a little better, or if that's not the time of day for them, find out when the patient feels best normally, and that's when we want to do anything that requires activity. We want to allow them adequate rest before we require them to do anything. We might space out. We don't want to cluster our care too much, because you think if you go in and you sit him up and give him a bath and feed him and shave him and have him ambulate, blah, 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 that's a lot of activity all at once, and it can really fatigue the patient. So give them their bath, let them rest. Sit them up in the chair, let them rest. They need to walk somewhere, then let them rest. So if we want, so we try and space out the activities that have adequate rest in between. Want to make sure they're getting adequate calories and staying well hydrated. If their iron counts get low, we can give them ferritin, serum ferritin iron injections, like you studied iron deficiency anemia in level 2. If their serum, if their serum proteins are low, we're going to give them albumin. If their H&H is low, we might have to transfuse if the hemoglobin drops below 7. You know, a lot of times in healthcare, we use 8 as our magic number, but these patients can be a pretty significant anemia. So we may hold up transfusions unless they get below 7, and then it will be patient and provider determination. Okay, the GI effects. Emesis is singularly the most complained about and most pervasive. We talk about fatigue, we talked about bone marrow suppression being common, but emesis is the most discomforting for a patient. If a patient is throwing up a lot, they're losing body acids, so they might develop metabolic alkalosis. They might become dehydrated. Their intake and output will be off. They might be having more fluid loss than fluid intake. If somebody is having a lot of emesis, we want to put them on a non-irritating, low-fiber, high-calorie, high-protein diet. The fiber can cause bloating, abdominal fullness. That's just going to make it worse. So the high-calorie, high-protein diet, because they're going to not be eating as much. They feel really bad. They're throwing everything out. So we want to maximize the nutritive value of the things they are getting. We can give them antidiarrheal, antimotility, antispasmodic medications. We're going to talk about emesis more in a minute, so we'll come back to those. If they're anorexic, if they've lost 5 to 10% of their body weight, we want to start putting them on a regular weighing protocol. And again, high protein, high calories, small frequent meals. Nutritional supplements, protein shakes as needed. Okay, emetogenic potential of a neoplastic agent. Every neoplastic agent is actually, time came up there, is actually ranked as high, low, or high, minimal, low, moderate, or high emetogenic potential. It's got more of a chance of making you throw up. If they're high, over 90% of the patients that are on that drug have consistent chemotherapy-induced nausea and vomiting. So you want to give drugs with low risk, but so many of them do have high risk, but they're very effective on tumors. But remember, the mucosal linings of our GI tract rapidly redividing. In our gut, we have serotonin receptors that, well, serotonin producing things that the chemotherapy triggers, and we create more serotonin, and that serotonin travels to the chemotherapy trigger zones and just makes us feel very nauseated and have a lot of emesis. So, here's what I was just talking about. So we give chemo, and it causes pharyngeal, GI, abdominal muscle contractions, and enterochromatin cells of the GI tract release serotonin. And the serotonin travels to the neurons, and it goes to the brain to the 5-HT3 serotonin receptors, and they trigger the vomiting center in our brain and the chemoreceptor trigger zone, and it causes massive emesis, ongoing persistent emesis. So there's different kinds of chemotherapy-induced nausea and vomiting. Acute is like, I give you your medicine, the medicine caused it, so usually within the first 24 hours after chemo, the nausea and vomiting starts, and it may, if it lasts for longer, that first 24 hours, we call it delayed, where it can last for up to 120 hours or even longer. So you think 120 hours, what is that? That's 5-6 days, right? 5 days. So, and sometimes there's a few that even have longer. So there's chemotherapy, induced nausea and vomiting from the acute medication administration, that immediate nausea, and then the delayed nausea and vomiting that goes with so many of our agents. That's why we give antiemetics before our chemo, so that it's peaking right at the time of administration, and we give them round the clock, whether the patient thinks they need them or not, through the half-life of that drug, or through the emesis potential time of that drug. And then another kind of nausea that they may get, nausea and vomiting they may get, is anticipatory or learned nausea and vomiting, where every time they got chemotherapy, they threw up for a day or two. So now every time they see the nurse come in with the chemotherapy, they get nauseated and start throwing up just at the side of the nurse, or the side of the syringe, or the side of the medication. Not bad enough it causes it themselves, but then you got the psychological anticipatory nausea and vomiting going on. And then there's breakthrough nausea and vomiting. So we gave the Zofran or the other antiemetic prior to the treatment, but they have breakthrough nausea and vomiting anyway. And so we have to give rescue treatment, higher doses and various drugs to save them from that. And then refractory nausea and vomiting is during subsequent treatment cycles. So the next dose, the next dose, the next dose. All of our prophylactic and rescue nausea and vomiting things have failed. And the patient now has refractory nausea and vomiting, where they just keep throwing up and there's little we can do about it. Nausea and vomiting, patients say, interfere with their ability to run their errands, to play with their children, to work, just general overall ability to communicate with others. Their overall activity level decreases. It's just debilitating. So pharmacologic treatments for chemotherapy-induced nausea and vomiting. Well, we can give prochloroperazine, compazine. All of our nausea, our dopaminergic anti-nausea medications all have the zine ending. They're actually psych meds, zine, thorazine, right? But compazine, prochloroperazine, compazine, it's a drug that works on the dopamine receptors. Remember we did mood and affect, and when you're gonna do schizophrenia next semester, all the psych drugs have a strong effect on the dopamine receptors in the brain. So those zines are psych drugs as a co-use for them. But in this case, they also have antiemetic properties. So compazine specifically has been developed for its antiemetic potential. We use it a lot on our patients with chemo-induced nausea and vomiting. Well, you can use metoclopramide, that's Reglan, right? And haloperidol, that's Haldol, it's another one. But Reglan can be used as well. That's another common antiemetic we give. Zofran is probably the most effective thing. The serotonin reuptake inhibitors, the serotonin 5-HT antagonist, not a reuptake inhibitor, an antagonist, Zofran, which is ondansetron. I think that was one of the drugs you learned in your pre-medication quiz at the beginning of the semester. But they're used for chemotherapy and induced nausea and vomiting. No, not Zofran can be used with surgery and other times too, but they work really well on chemotherapy-induced nausea. Because remember that initial spasming, the salivation, the problems that the chemo cause the chromatographin cells to release serotonin, which in turn cause the chemoreceptor trigger zone to be stimulated. So we give the antiemetics, and those we'll give before treatment and round the clock throughout the emetogenic potential of that drug. We also can give corticosteroids. Corticosteroids reduce vasopressin levels and prostaglandin release, and that has an antiemetogenic effect. So giving prednisone, Decadron, dexamethasone, those drugs can reduce the nausea. And then amend these substance P antagonists like Amend, EMEND. It's a great drug. It has like a 72-hour half-life, so we can give it and it will last a long, long time. And we use it to augment the Zofran, ondansetron. We use it to augment. It's not a replacement. It's given in addition. So a patient will get their Zofran, and then they'll get a steroid and they'll get an Amend, a substance P antagonist, Amend, or a similar drug, okay? Other drugs that we can give that can be very helpful. I'm going to skip over the next one and we'll come back to it. Benzodiazepine, the lorazepam, the anti-anxiety effect agents have a great effect on nausea and vomiting as an adjuvant, not as a solo treatment, but given in addition to other antiemetics. They act on the GABA receptors, which dampen the neuronal activity, so it suppresses that neuronal activity that was causing the anticipatory nausea and vomiting. So if a patient's having a learned response, anticipatory nausea and vomiting, we're going to start giving them the benzodiazepine, specifically the razapam. So cannabinoids. We talk about marijuana use a lot throughout healthcare. Cannabis products can be used to treat nausea and vomiting. And Dronabinol, Marinol, trade name Dronabinol, generic name, can be given to reduce the nausea and vomiting. And for some patients, it works better than the Zofran and the Compazine. Some patients it doesn't work as well for. But it's the medical marijuana, Dronabinol. It's the actual pill form of that drug. I think we have it in liquid and pill form. All right. So we want these patients to keep their eye on their oral cavity, watch for stomatitis, watch for ulcerations and lesions, do good oral care with just water or normal saline and spit it out. Don't drink the saline. They should have a good dental exam and all the dental work done before they start their chemotherapy. So if you know you're starting next week, get in to see your dentist. Most patients with chemotherapy, remember they're neurotoxic. So they lose their sense of smell, sense of taste. They may get difficulty swallowing, and things may have an altered taste, so they aren't as hungry, everything tastes bad, and then they're nauseated too. The xerostomia we can treat with saliva substitutes. There's actually oral rinses and toothpaste that are meant to help you with improving salivation. Drink water frequently, suck on hard candies if you need to keep the mouth moist. You want, when you eat, if somebody has dry mouth or stomatitis, you don't want them to eat hard, sharp foods, things that irritate the mouth. You want high acid foods. So not fresh tomatoes with potato chips, right? Because that'll irritate your mouth. Not chili powder at this moment, right? Because that's going to be irritating. So high protein, high calorie, non-irritating, soft, easily chewed foods. No alcohol, not too hot, not too cold, and no smoking. Need I say it? All right, then there's the skin problem. So we've talked about chemotherapy induced nausea and how to manage it. You need to know Compazine, you need to know Zofran, you need to know Dronabinol, you need to know Amend, you need to know Lorazepam, all as treatments for that. A lot of drugs in this unit because of the chemotherapy and the treatments of it. A lot of students get pretty skitzed out about what chemo drugs do I need to know. It's not so much that you need to know the names of specific drugs. You need to know side effects of chemo, classifications of chemo, and global treatments for the chemotherapeutic side effects. As if I give you a specific drug by name, I'll also say it's an alkylating agent or a cytotoxic agent, cancer antibiotic. Only a couple of those specific drugs you need to know. I would say the platinol drugs. I would say vincristine as a treatment. I would say doxorubicin, adriamycin. Those three biggies we probably need to know. And if I think of another as we're going through this, I'll tell you. But enough of that. So on to skin reactions. So skin reactions from chemo and radiation can be dry reactions or wet reactions. If chemo is giving you dry, flaky skin, you just want to lubricate it with non-irritating lotions. So you don't want anything with metal in it, no alcohol in it, no perfumes in it, no additives. You want just plain lubricating, very easy on the skin, non-irritating, non-toxic stuff. I mean, yes, we all feel better when we get the frou-frou smelling, glistening, wonderful lotions, but what we're talking about is just a plain old Jergens hand lotion with no added scents and stuff like that. If it's a radiation dry skin, we don't put anything on it unless you have notified the healthcare provider and they've given you a specific direction that it's okay to use. Sometimes they will say A&D lotion is okay, sometimes not. We want no lotions with any oils in them, no perfumes, no chemicals, and only treatment with specific permission from the radiation oncologist, because the lotions can cause exacerbations of the skin condition. It can cause burning with the next treatment. It can cause further skin breakdown as it reacts with the cells that have been damaged through radiation. The radiation can also have a wet reaction where you got leaking fluids and third spacing because the skin has been damaged. Kind of think second-degree sunburn where you're oozing things through blisters. The wet reactions, we don't want to put anything on either. We're going to keep it clean. We're going to protect it from further damage. You might put a clean, sterile cloth over it and just protect it from any other irritation. Any patient who's undergoing radiation or has chemo-induced side effects of their skin should stay out of the ultraviolet light, stay out of the sunlight while the treatments are going on. And you should not shave or do anything irritating to the site. If you have a wet reaction or any open skin, you're likely to get infection in that site, especially if you have myelosuppression. So you want to make sure it's kept clean and dry and covered and not exposed to anything. You want to eat foods that are going to facilitate wound healing, A, D, E, vitamins, along with high calories, high protein, adequate complete fats, because cell membranes are made up of fats and proteins. No constricting garments, no belts, nothing to cut off perfusion to any of the skin, no deodorants on the skin, no heating pads, no ice packs, no hot water bottles anywhere near your treatment field where you're getting radiation. It will just further irritate that skin and cause further breakdown. Here's a picture of dry desquamation where the skin peels off because it's dry, or wet desquamation where the skin is removed and you got oozing of body fluids. So either one, both are unsightly, cause side effect, cause poor self-esteem in our patient, are distressing. Wet desquamation a little harder to manage. Alopecia, the hair loss. It's, again, all hair, eyebrows, eyelashes, pubic hair, arm hair, leg hair, hair on your head. So there's a lot of body image changes that are associated with that. Some patients swear by you put on a cooling cap that goes on your head, and it's like an ice cap. It runs cold water through the system during treatment to decrease perfusion to your scalp veins and scalp arteries. during the treatment. They swear by that helping with retaining hair. The hair usually grows back. I already told you different texture, color, whatever. You can use scarves, turbans, wigs, makeup, anything to improve that patient's self-esteem. So pulmonary fibrosis, another side effect of chemotherapy. It can be progressive, and if it damages the lung and scars it from chemotherapy, and that was the B drugs, the bleomycins, then those can be progressive, or bisulfans too, progressive and irreversible. So pulmonary fibrosis can lead to chronic lung disease after chemotherapy. So we're going to carefully monitor these patients that are undergoing chemo, and we have to weigh what's the long-term damage versus the good this drug is doing. Are we going to change medications or not? The patient, if they begin to get pulmonary fibrosis, cough, shortness of breath, later pneumonitis, inflammation in the lungs, and edema in the lungs. So they're going to get frothy sputum, coughing up wet stuff, starts with a dry cough. The treatment for this, bronchodilation, albuterol, nebulizer treatments, expectorants, cough suppressants. Bed rest. Rest is always good to control and spare your oxygen carrying capacity and oxygen usage, and supplemental oxygen in general to increase the percentage of oxygen that's filtering across your basement membrane in your lungs. The cardiovascular effects of chemotherapy. If somebody has pre-existing heart disease, they're more vulnerable to the cardiotoxic effects of chemo. Doxorubicin is the drug I've mentioned for this. That's adriamycin. That drug singularly causes more cardiac damage than any other chemotherapy we're using. But if the patient gets radiation and doxorubicin, they're really high risk for cardiotoxicity. Herceptin is also cardiotoxin, but doxorubicin's the biggie. If somebody's taking adriamycin, that's the other name for doxorubicin, adriamycin. Those mycins are organotoxic. We talked about some of them with ototoxicity, nephrotoxicity, neurotoxicity, but here we've hit adriamycin, doxorubicin, it's cardiotoxic. All patients who are taking doxorubicin for chemo will be given a lifetime dosing card they should carry with them all the time. So if they ever are on any other kind of problem where they need an antibiotic or more chemotherapy later, we want to know how much have they already had, and we don't want to get them past their maximum lifetime dosage. Geez, my nose is running today, and no, I don't believe I have COVID. I got allergies. It's a beautiful day. Reproductive effects. The radiation and chemo can have unexpected sexual side effects. You always want these patients to talk about that with their healthcare provider before they're started on the treatment. Some of these drugs cause infertility, some cause impotence because of the neurotoxicity, rather. So you want to have that conversation with the provider before they start it. If they start having effects of this and it's going to cause long-term problems, they might need counseling. So you certainly just want to know what you're doing. Sometimes with the sexual effects, if we think sterility in men especially is going to be a problem, we can have them do pre-treatment sperm banking. So if they decide they want to have children later, they can use their own sperm and do some artificial insemination with their partner later. Men with testicular cancer get treatments that commonly destroy their testes. And so, if they, men who get penile cancer, men who get scrotal cancer, men who get prostate cancer, high risk for some of these testicular cancer, high risk for some of these sterility-inducing problems. And so we would want to discuss pre-treatment sperm banking with them. Certainly a good idea. Okay. So nephrotoxicity, that's damage to the neurons that are feeding the kidneys. So the kidneys stop functioning well, right? Or not to the neurons, but damage to the kidney cells themselves. I'm sorry, it's neurotoxicity, damage to neurons. Nephrotoxicity, damage to the organ itself, damage to the kidney basement membranes, damage to the glomerulus. And so the kidney filtering actually changes. The patient's BUN, creatinine will go up. The urine output probably will go down. They may have weight gain from increased fluid volume retention. they talk about chemo brain, mental cloudiness. That's probably from the buildup of toxins that would happen as a result, as a result of the nephrotoxicity. But it also can come from the chemo itself causing neurotoxicity in the brain. So nephrotoxicity, a complication, kidney damage, BUN creatinine elevations. Patient might actually need dialysis after chemotherapy if we completely kill their kidneys. Hopefully we'll be monitoring this. If they have a highly nephrotoxic drug, the provider will balance out treatment effect versus damage and change drugs if they have to. The chemo brain, the mental cloudiness, if they have neurotoxicity from chemo brain, sometimes that's permanent. And you think the neural lemma and our peripheral nerves can regenerate, but the myelin in our central nerves, very slow or hard to remyelinate and to regrow. The brains in our head are the cells in our brain are permanent cells. So if they're damaged and destroyed, it's hard for those cells to regenerate. There may be some, but it's delayed, it's slow. That mental cloudiness, a lot of patients on chemo complain of, and they'll, even after they stop chemo, may have the effects of it for several years thereafter. Peripheral neuropathy, if it's neurotoxic, that means the nerves everywhere. So these patients might get those shooting, numbness, stabbing pains in their extremities, hands and feet. Remember the B on the chemo band, the vinca alkaloids caused peripheral neuropathy. So if they get that, gabapentin's a drug we've talked about before for the treatment of peripheral neuropathy. We talked about that when we were talking about peripheral neuropathies in the treatment of spinal cord injury and bone and muscle disorders. We talked about it, I think, back even in the first module that we were working on. So gabapentin, a drug that we specifically use for the pain, the neuropathic pain, to suppress those neuropathic symptoms. Steroids can be used to decrease the inflammation. We can use them topically to numb the area, like lidocaine cream to numb an area. Antidepressant medications in low dose can be used for neuropathic pain. Anti-seizure medicines like Tegretol and Dilantin can be used for the control of neuropathic pain. If the pain is really severe, last-ditch effort, we can give an opioid, but we're only going to do that if we can't control it through other modalities. Coping. If you got told you had a cancer diagnosis, there's always an immediate emotional response, and depending on the severity, the staging and classification of their disease, that can only get worse. If patients don't understand their treatment, don't understand their risks, uneducation and lack of knowledge is a great anxiety producer. So to enhance your patient's coping, we want to involve them in the plan. We want to help them plan for transportation to and from treatments if they're not able to transfer themselves. The Cancer Society has free services that volunteers help with that to transfer to radiation or chemotherapy treatments. We want them to have a good nutritional plan in place before they start their treatments, maybe working with a dietitian, and if they have symptoms once treatment started, refer them back. Lots of emotional support. They might need social supports with pastoral care or with a social worker or with some kind of psychotherapist to help treat depression and moodiness, anxiety. If we teach them their symptoms, they're managing the symptoms and how to intervene for themselves, it gives them more control of their life. They get a higher quality of life. We can offer community resources, social support services. We want to tell the patients how to decrease their anxiety, involve them in activities that are anxiety reducing. That would be activity, song, music, meditation, all kinds of different things, guided imagery. We want them to discuss their fears. We want them to face their fears, discuss their fears, and feel like they have somebody safe to talk about that with. We want to reassure them it's a temporary, because with cure, this is going to get better. Even with palliation, it's going to get better. We want to inform them of all the support vehicles available to them. All right, later effects. Sometimes even after chemo and radiation are done, weeks, months, and years later, you can have another effect. Radiation and chemotherapy and other immune suppressive treatments we do can cause a leukemia or a lymphoma 10 years later. So multiple myeloma, non-Hodgkin's lymphoma cancer of the bladder, kidney, ureters, osteosarcomas, fibrosarcomas, can all happen years later. Once the patient gets a secondary malignancy, those are usually very resistant to treatment. They aren't as responsive to our radiation and our chemotherapy. Another thing that can happen to patients if they had radiation and they got that dry or wet desquamation, when they start their chemotherapy a couple months later, they can get radiation recall where their radiation rash recurs. We need to find out if that rash is from a radiation recall or if it's a new rash from the chemotherapy. So a series of asking questions and finding out what the radiation did to their skin and where it was located, and coordinating with your healthcare provider can help develop a treatment plan so you know what treatment to do for that rash. Okay, biologic and targeted therapies. These are therapies that can be used alone or in combination with surgery, radiation, and chemotherapy. So biologic therapies are not truly chemotherapy, but they're still a drug that we're giving the patient. But they do one of two things. They alter the body's response to the tumor cells. That's pretty much what they do. The body, I have a lung cancer and I have a side effect of that, and I give a medication to alter my response. Or I'm on chemotherapy and I have myelosuppression, so I give a drug to alter the response to the treatment or to the tumor. Our biologic therapies are targeted. They always respond specifically to certain types of cells. They bind with cell receptors that are important to that tumor growth. So if we can block that cell receptor, that tumor won't grow, right? Okay, so we have lots of different types of targeted therapies. Now think back to the immunology unit at the beginning. mAbs and Fabs are immune suppressant, right? mAbs and Fabs block the immune response. If some of our drugs, some of our items are tumor-specific antigens that are being attacked by other things, then our targeted therapies will have receptors for antigens on the surface of the cell. So look at these drugs. The drugs are in the outer ones in colors. Trastuzumab, MAB. Alemtuzumab, MAB. Bevacizumab, MAB. MABs, immune suppressant biologic therapies. We use them with our autoimmune diseases to do the same things. We just had different sites of action and different antigens they were acting on. So biologic and targeted therapy can kill cells without damaging normal cells. They can kill tumor cells, but not damage normal cells. The targeted therapies, tyrosine kinase inhibitors, monoclonal antibodies, vascular endothelial growth factors, proteasome inhibitors, interferons, cytokines. Those are all classifications of drugs in the biologic and targeted therapy category of medications. Most of these cannot be delivered orally. They have to be given subcutaneously, intramuscularly, or intravenously. They're also not interchangeable. Just because you were on one drug doesn't mean you can substitute another drug. And we're going to specifically match that drug to the type of cancer the patient has and what receptors it acts on. So interferons, they inhibit DNA and protein synthesis. Remember, interferons, alpha and beta interferons, those were drugs we talked about with multiple sclerosis. Remember that? So that's certainly, it's the same category of drugs. Those interferons were developed to treat colorectal cancer. They work specifically for colorectal cancer. So it was, those interferons were developed for cancer treatment, and then we found a concurrent use with autoimmune disease. So, but what interferons do, they inhibit DNA and protein synthesis so the cancer cells can't grow rapidly. Side effects of interferons are the same as they were back when we did multiple sclerosis: flu-like symptoms, weight loss, fatigue, depression, cognitive function decline. So big side effect, flu-like symptoms. Interleukins, interferons, interleukins. Both of these are working on the immune system. Interleukins induce biologic things that activate the immune system to alter the actual function in the cancer cells themselves. They stimulate our B and T cells that are our immunological surveillance to try and take out these abnormal cells. They activate our natural killer cells that cause cell death of cancer cells. Biggest side effect of interleukins is that they cause capillary leak syndrome. So all your little mini capillaries lose vascular fluids to the interstitial spaces, and that causes a fluid shift, which can lead to dehydration symptoms. They don't have a loss of fluid, but they have loss of fluid in the vascular space. So they get low blood pressure, they get dizziness, they get orthostasis, and they have vascular permeability, so they might get edema and that kind of stuff. But the hypotension is a big problem in the orthostasis that goes with that, dropping blood pressure. Another thing the interleukins cause is bone marrow suppression, just as the chemotherapy agents did themselves. Notice these aren't bad nausea, vomiting side effects, though. So if your patient's throwing up a lot, these will work on them. It helps with the emesis. A little bit of nausea, vomiting here. Monoclonal antibodies. They bind to target cells and destroy them. We have to give them by IV infusion. And their infusion symptoms, their symptoms from this drug are usually infusion related. We can give them often some Benadryl or some other treatment beforehand to help reduce these symptoms. But while they're getting that IV and immediately thereafter, they might have nausea, vomiting, and chills, fatigue. And then monoclonal antibodies can cause cardiotoxicity, bone marrow suppression, and they have a risk of anaphylaxis. That's foreign proteins. It's an antibody, so it's a protein itself. Oh, wrong way. Okay, tyrosine kinase inhibitors. They reduce an enzyme that regulates cell proliferation. So it stops the enzyme that is causing that cell to regenerate and survive. So side effects, rash, dry skin, lung disease, and an infusion reaction also. You don't have to memorize all of these. I know you know interferons from earlier. I think interferons or interleukins, commonly given drugs. And for the others, just recognize their name. It's a biologic therapy. It's working not as chemotherapy. It's altering the body's response. We're fixing to get into some hematopoietic biologic response therapies. You're going to have to know all the drugs in that category. Okay, proteasome inhibitors, again, bone marrow suppression, neuropathies, but the proteasome activities regulate our cell growth, so if they can inhibit, they can stop cell growth. And angiogenesis factors. Remember, the cancer cells have the unique ability to make their own blood supply. And that caused that tumor to live in that new site that it metastasized to by giving it its own capillary bed to get oxygen and nutrition from. So the targeted therapies here with the angiogenesis inhibitor, if the tumor is metastasizing, this will stop those metastatic sites from setting up a blood supply. So they can't get nutrition and oxygen, the metastatic sites won't thrive. So these drugs are very good at doing that. Hematopoietic growth factors. I said this was the category you needed to know all the drugs in that I've got mentioned on the slides. These are colony stimulating factors that improve your recovery from bone marrow suppression and reestablish bone marrow function and tell the bone marrow to do its job. So very valuable for that myelosuppression that chemotherapy causes. So 3 major drugs in this classification: erythropoietin, EPO, Epogen. This drug stimulates erythropoietin, which was made in the kidney, stimulates the bone marrow to make red cells, right? So this particular drug stimulates this colony stimulating factor, CSF, not cerebrospinal fluid, colony stimulating factor, stimulates the precursor to the red cells that tell the bone marrow to make more red cells. So it's really giving them a natural hormone they already have, but it's giving more of it to get the red cells to mature and develop and release. So it will help the fatigue and the anemia from chemotherapy. Interleukin 11 or Numega. Interleukin 11 or Numega. That is a platelet growth factor. So if your patient has thrombocytopenia, bruising, bleeding, and we were worried about their platelet counts, then we can give this drug to improve their platelet count. Adverse effects of this: mouth sores, edema, shortness of breath, tachycardia. Neupogen, filgrastim, and pegfilgrastim. Neupogen. These increase white cells. So if you have white cell suppression, leukopenia, and you're at risk for infection, I can give this drug and elevate your white count. So erythropoietin for red cells, interleukin-11 or Numega for platelets, and Neupogen or filgrastim or pegfilgrastim for white cells. So those are the three hemopoietic growth factors that we give to combat the myelosuppression that can be so bad. These drugs have just changed the outcomes for so many of our chemo patients, allowed them to have the energy to go about their activities of daily living, allowed them to not be as susceptible to infection. We actually have to monitor these and try and target them based on the nadir of our chemotherapy. Nadir is the point at which bone marrow suppression and the other side effects are at their highest point between chemo. So if I'm giving my patient a round of chemo once a month, so 5 days of chemo once a month for 6 months or 3 months or whatever the treatment is. So I give you 5 days of chemo, and then in a month you're supposed to have another 5 days. Well, my nadir is at the half-life of that drug when my bone suppression is at its worst. So my white count's its lowest, my red cells are at their lowest, I'm the most fatigued and the most susceptible for infection. The provider will come along and make sure that we can give them these hematopoietic factors so that they are peaking at a time the nadir would be at its lowest. So very helpful for our patients. Okay, for most of these biologic treatments, flu-like symptoms were a side effect. So giving them Tylenol before the treatment and every 4 hours for the next 24 to 48 hours after treatment. If they have a fever, meperidine, that is Demerol, and that will control the chills and the shakes if they happen to get chills and shakes. We want them to monitor the vital signs and temperatures, rest for the next day, get help at home if they need them for their ADLs because they're going to be really fatigued, and make sure they're continuing to take adequate food and fluids if they have nausea or anorexia. Hemopoietic stem cells. This is not chemo, this is not radiation, and this is not a biologic therapy. This is a transplant of your own or some other person's bone marrow or stem cells that's healthy to replace the stem cells that are diseased. So bone marrow transplant is a form of stem cell transplantation. We also have peripheral stem cell transplantation. These are used for rescue. If the chemotherapy is in really high dose and they're severely myelosuppressed, and their cancer was bad, it didn't respond to normal chemo, we had to give them high doses, they got significantly myelosuppressed, and we wiped out their bone marrow. Or if their radiation wiped out their bone marrow. Or if their chemotherapy became resistant to the normal drugs, we had to give a different combination in high doses for resistant cancers. And in some leukemias, and we're going to talk about leukemia in a different lecture, they get a blast crisis. So they have no mature white cells, and their blast cells, which are immature baby ineffective white cells, are so high, and we can do stem cell transplantation to wipe out that overgrowth of the leukemic cells and hopefully restore healthy bone marrow. To do a bone marrow transplant, we try to eradicate the tumor through high doses of chemo. It wipes out the bone marrow and the patient's own immune system. So this is high risk for your patients. The patient's immune system is wiped out and may take a long time to redevelop if it even will. Oh, I think I went the wrong, nope. Stem cells are either allogenic, autologous, or synogenic. Allogenic is, I get it from somebody who's the same blood type as me. Autologous is my own blood cells. So when I'm in a period of remission, I'm doing great, my blood counts are high, I don't have active cancer, I'm in remission, I can donate bone marrow or stem cells, so that if I have a recurrence of my cancer or a recurrence of my leukemia or whatever, I can get my own bone marrow, and there's less risk of rejection or complications as it would be from getting it from somebody else. Where do we get stem cells? Bone marrow, peripheral blood, or umbilical cord blood. So when you're born, you can actually pay to have your umbilical cord blood saved, frozen, and used later, or you can donate it to somebody else who's HLA compatible. If you're going to get your own bone marrow, or somebody, if you're going to donate bone marrow, we'll do bone marrow aspiration and take aspirates with a large needle out of the bone marrow. Or we now, through a process similar to plasmapheresis, and we talked about that in our immune module back at the beginning, where you go to the chair and they pull out your blood, take out what they're looking for, and return the rest, in this case, looking for stem cells. And then we can give peripheral IV stem cell transplantation back. I love that bone marrow transplant and peripheral stem cell transplant given through an IV. The stem cells move into the body part they're supposed to move into. Bone marrow will give through IV and it'll move into the bone marrow, set up housekeeping, and start to produce normal cells. Autologous stem cell transplant, you have a patient who will harvest healthy marrow. We'll treat those stem cells to make sure no malignant cells are in them. We'll wash it to make sure there's no bone fragments in it. And then we'll give the patient back those stem cells when they need them after their chemotherapy dose. If we're getting stem cells from bone marrow, to harvest bone marrow, the patient will have anesthesia, either general or spinal anesthesia, or lots and lots of local anesthesia, but quite often we'll just do general anesthesia if we're going to take it from the same patient. If you're donating bone marrow, you'll go into the bone marrow bank. They'll do multiple aspirations under local anesthesia. So they'll take a coring needle and aspirate bone marrow from multiple sites, sometimes up to 100 aspirates at the iliac crest of the hips, most common site, both hips. Sometimes we can do the sternum too, but a little more risky doing aspirates from your sternum. We process that marrow, remove the bone fragments, wash it, preserve it, and then when we need it, we'll infuse it through intravenous infusion to the patient. We talk more about this next semester. Stem cells from the peripheral blood, you go on like a plasmapheresis machine that separates the stem cells out, takes 2 to 4 hours. They may have to do it several times to get enough stem cells. And then when the patient needs it, then they can get their own stem cells back. Or you can donate stem cells to give to somebody else. Umbilical cord blood, also the same thing, but we have to get that at birth from a baby and then store it later. Or we can transplant it to an adult who's the same HLA type. HLA, human lymphocytic antigen. It's like we blood type, but we also white cell type them to make sure their lymphocytic antigens won't cause rejection. Okay, we have the National Bone Marrow Donor Program. You can register as a bone marrow donor, and then if you've got a child who's your blood and HLA type that needs a bone marrow transplant, they'll call you up and see if you're willing to come in and donate. Okay, complications of bone marrow transplantation or human stem cell transplantation. There's early and late side effects. Infection, bleeding, those are early things. Obviously, we stuck a needle in them and an infection could result. If we wiped out their bone marrow and they haven't started to regenerate white cells, they can have a really bad infection or bleeding from platelet loss. GVHD, acute graft versus host disease. We will talk about that next semester. I'm thinking these things are a little bit too complex for you at this point. We're going to come back and do that next semester. So just know that there's early and late complications from human stem cell transplantation. Enough of that for now. There's 3 types of acute rejection. There's a hyperacute, acute, and chronic, and we'll cover more of those next semester. So again, just think, okay, I've heard of those. So next semester, they're not new to you. So a hyperacute occurs immediate, right away, the first few hours after transplantation. Acute within weeks, and then chronic after several months or several years after the treatment. All right, we also now are doing experimental treatment with gene therapy. We're actually going in and trying to take pieces of DNA out and transplant healthy DNA into cells and chromosomes that are damaged. to correct the defective genes. Still experimental, not using it widely, but it's out there. We may be seeing that in our lifetime. Okay, malnutrition is another complication of cancer for a couple of reasons. The treatments, we talked about stomatitis, anorexia, nausea, and vomiting. Obviously, you're not going to eat. The cancer itself carries a high tumor burden, a high calorie burden from the cancer itself. And so the patients may have fat and muscle depletion. Plus, they're sick. They may be spending more time resting and in bed. That might cause muscle atrophy. So we always add supplements when the patients started to lose at least 5% of their healthy body weight before they had cancer. And we know then at 5%, they have a problem with calorie and protein balance and malnutrition. We'll start monitoring albumin and prealbumin levels, and we have to give enteral, TPN. Enteral is feedings, like tube feedings through gastrostomy tubes or NG tubes. Usually we'll do a longer term gastrostomy tube. Or parenteral, like total parenteral nutrition through your IV. Then we can give those to give supplementation to their diet. They also have altered taste. So we're going to experiment with seasonings and flavorings to find something that they like the flavor of, and then use that flavoring in a lot of their food to try and promote their eating. Infection, a global overarching problem for so many cancer patients. Infection is the #1 cause of death in cancer patients. So the primary site of infection is lungs, like pneumonia, GU, like urinary tract infection that turns septic. Especially if they have bone marrow depression, you get an infection, you can become septic very quickly. Oral lesions and the mouth can introduce infection to the body. And if we're getting peritoneal chemotherapy, then the peritonitis and peritoneal infection can be very severe. We talk about more about that next semester too. Let's see, ulcerations, compression of organs, and neutropenia can all contribute to the infection. Oncologic emergencies. This is, I think, the last segment on these slides. There's several conditions that are considered an oncologic emergency. And those emergencies, as soon as we identify them, we call the provider or we start introducing treatment for them because they are all life-threatening. They can be obstructive, metabolic, or infiltrative. Aren't those great words? So obstructive oncologic emergencies. One of the most common is superior vena cava syndrome. Patients have breast cancer, lung cancer, spinal tumors, things that are happening up in the upper body. The tumor grows and causes obstruction and or thrombus in your superior vena cava, and that causes a backup of blood. So you'll get distended veins, superficial veins in the neck and the upper chest, facial and periorbital edema, and they might get headaches and seizures from the backflow of blood into their head and the increased intracranial pressure. And if they're having seizures and increased intracranial pressure, that's certainly an oncologic emergency. If we're obstructing fluid back to the heart, their cardiac output's going to drop. So we have to do something to shrink that tumor up. We will take them for a debulking procedure, or that's a surgical procedure where we remove large chunks of the tumor and make it a smaller tumor burden, or radiation to shrink the tumor. Another spinal cord oncologic emergency would be spinal cord compression. It's going to give them signs of spinal cord injury, just like we talked about in the mobility unit. Persistent back pain maybe start, but then motor weakness, paresthesias, paralysis can occur. It may cause them to not have continence and bowel or bladder anymore because of loss of spinal cord function. So again, the treatment would be debulking, getting that tumor reduced, the tumor that existed in the area of the spine that was pushing on the spine. A third spacing syndrome, where the capillary leakage has caused so much fluid to leave their vascular space that it causes significant hypotension and hypovolemia. Will drop urine output, cause tachycardia, symptoms like shock. So our treatment for that would be to replace fluids and electrolytes and give them albumin and other plasma proteins to pull the fluids back into their bloodstream. Because plasma proteins have a colloid effect where they pull fluids to them. Then there's metabolic emergencies. IADH, syndrome of inappropriate ADH. ADH causes you to not diurese. So if you're making a whole bunch of it, you're going to retain fluid and have a dropping urine output. Okay? Syndrome of inappropriate ADH. You got too much ADH, antidiuretic hormone, so it's going to cause you to have less urine output and more fluid retention. Another metabolic emergency where the tumor can cause a change in metabolism and you can get hypercalcemia, or you can have tumor lysis syndrome. We're going to spend a little time on that one in a minute. Septic shock is a metabolic emergency caused generally from infection. And DIC, disseminated intravascular coagulation. I think we talked about that briefly already this semester, but that's where you use up all your clotting factors and the patient bleeds from all kinds of stuff because they've used up their clotting factors. I know we talked about that. Okay, so syndrome of inappropriate ADH. The cancer cells themselves may create ADH, or something may be happening in the body to have the body make more ADH. Either way, they have too much ADH. Some cancer cells have the unique ability to create our body's own natural hormones. When they undifferentiate, you get this undifferentiated cell and it kind of goes, oh, I'm going to become a hormone producing cell, and it starts dumping hormones in the body. And ADH is one of the more common ones, and it happens most often in lung cancer. Lung tumors are really bad about producing ADH. So what do we do if somebody's got so much fluid retention, but it's causing, they're losing, they're still can excrete sodium through their tubules, but they're retaining the water. The water is being retained. So we're going to put them on a fluid restriction, and if necessary, if they're really bad, cautiously give 3% sodium chloride. It's given cautiously. Hypertonic saline can be fatal if you're not closely monitoring lab values. So you need to be very cautious with the hypertonic saline. Usually we'll just do a fluid restriction and a normal saline IV in small amounts until we get the volume back. But if we have to, we can give 3% to get their sodium levels up to a safe level. Hypercalcemia. Some hormones, the ADH hormone is produced by some tumors. Parathyroid hormone, PTH, can be secreted by some tumors also, often osteosarcomas, bone cancers. So if they produce parathyroid hormone, it's going to make our calcium levels increase. And hypercalcemia gives you apathy, depression, fatigue, EKG changes, nocturia. So it can be life-threatening because of the cardiac changes. It'll cause electrocardiogram changes, which is a rhythm of the heart. The rhythm of the heart may actually change. So we have to treat the hypercalcemia by getting more calcium in the body. So how do we do that? We hydrate them, we give them, hypercalcemia is treated by getting calcium out of the body. I apologize, I misspoke. Hypercalcemia from hyperparathyroid elevates the calcium. We've got to get the calcium out of the body. So we can give them a biphosphonate. That's a drug that will put the calcium from bloodstream on the bone and make them calcify their bones. So it will drop your serum calcium. Giving diuretics like Lasix can cause you to micturate off your calcium. So you'll pee it off and then you'll put some on your bone with the biphosphonates, or we can just hydrate them and dilute it out a little bit if they need more fluids. Tumor lysis syndrome, another oncologic emergency, happens a lot with certain lymphomas and then other large solid tumors where we give them a big dose of chemo and lots of cell kill happens and lots of tumor cells are destroyed and they open up and they dump their contents into your vascular space. We killed cell lysis. The cell broke apart and the cell contents were dumped out into your vascular space. So serum phosphates will go up. Remember all that ATP and 2,3-DPG, all those other phosphate-rich chemicals inside the cell will cause your serum phosphate levels to go up. And when phosphate levels go up, calcium levels go down. So we have hyperphosphatemia and hypocalcemia. And then it can cause renal failure. These metabolic changes put an extra taxation on your kidneys, causing renal failure. The uric acid levels will increase because inside the cell, there's a lot of uric acid, so they get hyperuricemia. Tumor lysis syndrome can be fatal within just a few hours if we're not cautious about it. So let's look at a patient. So here's a 64-year-old male, Mr. B. He has a history of chronic myelogenous leukemia, which we're going to talk about in the next lecture. White count is 64,000. That's a really elevated white count. With leukemia, the tumor cells are the white cells. They're just bad white cells. They're not functioning. So the white cells are usually high. So here we have a 64,000 white count. He was treated with Trienda, okay, an alkylating agent on days 1 and 2. After the second dose, flank pain. That sounds like kidney pain, right? Shortness of breath. He was told to come back to the infusion room where we immediately did a review of systems and a physical exam on him. He had decreased urine output, painful urination, loss of appetite. Thankfully, his cardiac, no chest pain, right? We drew some lab. We found that his BUN is 50, really high. His creatinine is 4.9, really high. They're proportionally high together. The kidneys, in a 1-to-10 ratio. Keep that in mind. Uric acid is 19, also very high, and serum potassium 6. Remember, more potassium is inside the cell than in the serum, so we had tumor lysis. All that interior potassium inside the cell was dumped, so they get hyperkalemia, hyperphosphatemia, and hypocalcemia. On your EKG, you saw tall T waves. There were P, the QRS, and then the T. The T is the ventricular repolarization. Really tall T waves, that's indicative hypocalcemia. Heart rate 88. Allopurinol, that's uric acid. Oh, I'm sorry. The meds we're going to give is allopurinol. That's the treatment for hyperuricemia. So he was already taking that for gout or a prevention during the chemotherapy. Something happened, he needs more. He didn't get enough uric acid reduction. Okay, so what did we do for him? We started a normal saline at 200 mils an hour to hydrate him and wash in a filter, get all those hyperkalemia, hyperphosphatemia, get those levels back to normal through fluid replacement. Admitted to the medical oncology unit. We put him on telemetry, put him in a catheter so we can monitor his urine output because his kidneys are taking a hit. Sodium polystyrene sulfate, Kxalate. Remember, the patient's potassium was really high, not only from tumor lysis, but also from the glomerular damage in the kidneys. So both things cause hyperkalemia. Sodium polystyrene sulfate is this sodium exchange resin that exchanges sodium for potassium in your gut. It causes you to poop out the potassium and retain the sodium instead of retaining the potassium in your bloodstream. So it causes the potassium to shift into the bowels. We can give it by enema, we can give it orally. And then the other drug that we started this patient on was rasburicase, which is it's a quick acting decreasing uric acid level. Okay, so when a patient has acute kidney injury with high uric acid levels and tumor lysis syndrome, we will change them from their allopurinol to the rasburicase, Elitech. Great at treating tumor lysis syndrome. So what we had to take care of this dumping of the cells. And remember, this guy had a lymphoma or leukemia. I guess he had CML, right? So what we saw is that after the second dose of chemo, he had this dumping of all these metabolites from the inside of a cell. And the renal failure is life-threatening. So is the hyperkalemia is life-threatening, and hypocalcemia, life-threatening. So the hyperkalemia, weakness, cardiac dysrhythmias. Hyperphosphatemia is going to cause low calcium and acute kidney injury. Hypocalcemia causes seizures. That can be life-threatening. tetany of the muscles. It can even happen in the vocal cords in the airway. Hyperuricemia, again, is going to cause acute kidney injury. So to treat the hyperkalemia, we give insulin, which pushes potassium into your cells, and Kayexalate, which causes you to eliminate potassium through your bowels. We can give hyperphosphatemia. For the hyperphosphatemia, we can give the phosphate binders. I think that might have been a drug you learned earlier this year. Calcium acetate binds phosphate from your diet in your gut so that you can't absorb it. And we're also going to reduce dairy products. Take away the milk, the yogurt, and the cheese, because this gentleman doesn't need any more phosphate in his diet. Hypocalcemia, we're going to treat by managing phosphate. Because remember, if phosphate's up, calcium is down. If calcium is up, phosphate is down. So his hyperphosphatemia is what caused the hypocalcemia. So we want to get the phosphate down, and we'll bring the calcium up. Interesting that the phosphate binder was a calcium-based drug. So it's going to treat the high phosphate and bring the calcium up simultaneously. And then for hyperuricemia, we're going to give the rubricase, or we can give the allopurinol. You can't give both simultaneously. One affects the other. And so you take them off the allopurinol when you start them on the other. Okay. So the symptoms of the three big electrolyte imbalances are listed on this slide. So that can help you learn this. I just like the pictorial mechanism. So here's your nurse. We've decided to treat this gentleman with rubricase. I'm going to get it right eventually. And we're going to do a medication reconciliation to make sure we hold or stop his allopurinol, because they affect each other. They interact with each other. Allergies will be checked to make sure we're not giving him anything that we're going to, well, we'll come back to that now. History is checked. We check his medical history to see if it's a G6PD deficiency. That's a chemical in the blood. If they have a deficiency of G6PD, it will cause, and we give the rubricase, then it's going to cause hemolysis, more breakdown, but this time of red cells. It's going to break down their blood cells. And so that's a toxic effect of this drug. We're going to teach them so he knows the signs and symptoms of anaphylaxis, because there's a lot of anaphylaxis overlap with this drug. We're going to assess his vital signs. We're going to stay with him for at least a full 15 minutes monitoring to make sure he doesn't have an anaphylactic or significant drug reaction. So our management of this particular drug, get a baseline uric acid level, especially for patients with leukemia, lymphoma, and solid tumors. They're getting a lot of heavy-duty anti-cancer treatments. Treat them about the hypersensitivity reactions, monitor for them. Don't administer this drug to anyone with the G6PD deficiency. Methoglobinemia is abnormal hemoglobin that can't oxygenate. It overgrows in our tissues, and this drug can cause that. So you have red cells, but they're not oxygenating well, and that can cause your patient to turn blue and not perfuse his organs. So blood testing for uric acid done 4 hours later, and we're going to repeat it every 4 hours until we think our tumor lysis syndrome has gone away. Other symptoms we're going to do his BUNs, his creatinine, his serum electrolytes, his calcium levels, and his phosphorus levels regularly. Oh, okay, that's the end of tumor lysis. So treat the hyperkalemia, treat the hyperuricemia, watch their kidney failure, right? And if they have hypocalcemia, keep an eye on them for the tetany and the other problems associated with cardiac problems associated with hypocalcemia. Okay, other oncologic emergencies, infiltrative emergencies. This is from the tumor infiltrating other tissues. Around the heart is something called the pericardial sac. It's a loose connective tissue sac that surrounds the cardio muscle, the cardiac muscle itself. It's the outer lining of the heart. The heart has endocardium, myocardium, and pericardium. It's just a loose-fitting fibrous sac. A lot of times when patients have cancer, the tumor itself will secrete fluids, or that'll have infiltration into this cardiac sac, and they will get pericarditis, inflammation of the external sac, the pericardium. And so what happens, that inflammation causes fluid retention in the sac, As fluid builds up in the sac around the heart, it's putting pressure on the heart, decreasing the ability of the heart to contract and expand with each heartbeat. So cardiac output is ultimately going to drop, and the force of contraction is going to drop, and the patient's going to have all this pressure in their pericardium. The patient's going to complain of chest pain, heaviness, shorted breath, difficulty swallowing, difficulty breathing, cough, anxiety. Something's wrong. I don't know what it is, but something's wrong. Their pulses will be very high variability, pulsus paradoxus, where their pulses get stronger and shorter, like weak and stronger, weak and stronger. Heart sounds will sound distant and muffled. So what do? We have to get the fluid out from around the heart. So we might take into surgery and establish a pericardial window, open an opening in the sac to drain the fluid out. We can put a pericardial tube in, like a pericardial chest tube, or we can put an indwelling catheter there to drain the fluids off. That is the end of this particular content. So I will get this uploaded, and I'll talk to you next about leukemia and lymphoma.